शाहजी
सर।
शाहजी
सर।
या पोस्ट बनाओ।
हाँ सर, मैंने कॉल किया, सबको इन्फॉर्म किया सर।
मैं बोला को होस्ट बनाओ।
हाँ सर, बना रहा हूँ बना रहा हूँ।
हाँ, क्योंकि फिर वो इरेलेवेंट आता है ना सब। वी हैव टू
हाँ
कंट्रोल
सर, हाँ।
दैट।
Good afternoon, Mr. Yogesh. How are you?
Yeah, Dr. Vanitha, how are you?
All good.
Good.
Mr. Saj, I would request you make me also the co-host because last time we had difficulty in controlling the.
Yeah, madam. Yeah, because
Thank you.
I have received so many feedback after the meeting, soon after meeting. So we
Yeah.
have to see that. And we have to give the instruction also in the beginning. So please keep your audio and the video switch off. So at least people should understood that.
Yeah, I think in the
Yeah, and
end of
most of the
the.
time, globally people are watching this popular webinar. So it gives some different look of our series. At least decorum should be the maintained.
Yes, I think they couldn't hear the voices, disturbing voices, those who were
Yeah, even
contributing
the
to it because we
video
didn't
and the
have.
attire. Video and the attire of the people should be noticed by the others. Hi, Dr. Binu. So Dr. Ranjan will be joining, madam?
No, I think he has a meeting in Mumbai today. So he's traveling. So
Yeah.
he's.
Even though I am
Yeah.
also traveling, I am also traveling. But
Yeah,
just
I was told actually the executive board meet was supposed to be today. That was canceled. Yeah, I mean, we were told it would be difficult for anybody to be there. And Dr. Ranjan gave a go that since everything was arranged to go ahead with it.
Yeah. Welcome, Singarolu, sir. Yeah. You are muted, sir. Good evening.
Dr. Anand is around?
I am not seeing Dr. Anand here. Maybe in the
Yeah, it is 5 more minutes. I was just trying to check if
Yeah,
he's.
Saji, can you call Dr. Anand?
Yes, sir.
Yeah, call him.
So I don't have his number, sir.
I'm trying to call him.
So make a habit of taking numbers of email ID and the whole data.
Okay, sir.
Yeah. Hi, Dr. Muhammad Salman.
Yeah, hi.
Hi.
Hi, doctor. How are you?
Come for the webin. Hi, Vanitha.
Yeah, we are waiting for you. You can sign in, doctor. Do you want the link again? Okay. Yes, doctor. No, it's for everybody. Please circulate, doctor. We it's going on this way. We circulated in the IAP platform also. Thank you, Doctor. Yes, Doctor. Yeah. Thank you, Doctor. Bye. Hello, Dr. Mohammed.
Yeah, hi, Dr. Vanessa. How are you?
Good.
Good. Dr. Wafa, she joined? Still?
No, she's not. Would you please call her?
Yeah, I will.
Thank you. Dr. Anand is having some difficulties. I'm just guiding him. He'll be here in a moment.
Dr. Wafa, she will join soon. I call her. Actually, I just finished my duty today from 7 to 3. So,
While we are waiting for the time to tick in, we are scheduled to start at 4 o'clock Bahrain time and 6:30 Indian Standard Time. I will begin with introductions while we are waiting. The main speakers are Dr. Anand Rao and Dr. Wafa Madan, who are pediatric rheumatologists. And yes, the theme today is pediatric rheumatology. In the meanwhile, I would take a moment to talk about who we are and how we thought about these webinars and what are the schedule and what is something we can foresee. To introduce the IAP dignitaries who will be around, Dr. Yogesh Parekh from IAP I will call upon Dr. Yogesh to talk a few words after I introduce whilst we start, after the speakers sign in. I am Dr. Vanita. I'm the IAP Bahrain president. I'll be your host and the moderator for today's CME. As I said, today's theme is pediatric rheumatology. As a word about who we are a collaboration between IAP for the delegates who are joining in from Bahrain. An introduction about IAP would be needed. Otherwise, IAP is a very popular organization, a collaboration conglomerate of 50,000 plus pediatricians across the globe. And they serve the motto of continuous medical education for pediatric practice community in India and across the globe. We in American Missions are in the collaboration with them to bring you high quality CMEs from pediatric specialties every month. It would be scheduled 4th Sunday every month, 4 p.m. Bahrain time, 6:30 Indian Standard Time. We have covered pediatric specialties ranging from pediatric endocrinology, neonatology, nephrology, pulmonology, and we did have a live session collaborating various subspecialties, including ER and ICU. Here we are with exciting subspecialty, rheumatology, pediatric rheumatology. It is exciting because it's really an intriguing subspecialty for all pediatricians. They are the frontliners who are diagnosing most of the cases, especially the ones listed for today's discussion, Kawasaki disease and GIA. And how far are we to go? How far are we to be updated in these conditions? Both the conditions are being undergoing lots of revision, and the updates, Kawasaki disease, the recent AHA updates and revision, and JIA, the ILR revisions. So it will be very interesting to hear from the speakers regarding this and how the pediatric practice community will be benefiting from it. And what's the exciting future for these two conditions in the future? We will discuss before seeing an interesting evening today. I did not see both the speakers signed in yet. In the meanwhile,
Dr. Anand is here, madam. Dr. Anand already joined.
Dr. Anand, welcome. I will make a
And
more
Dr. Vasant Kalatkar is also
introduction.
here. Vanita, Dr. Vasant Kalatkar is also joined. I am President. Dr. Basavaraj is also here.
Oh, that's an interesting star panel. Okay.
Good
While
evening.
we wait, hello, Dr. Vasaraj. How are you?
Yeah, doing well. Doing well.
Thank you for joining in.
Good evening, all.
Our president is there. Okay.
Yes. Okay, as I was talking about, while we get started with the actual CME, I would like to invite Dr. Vasan to have a few words of introduction and encouragement to us before we get started. Dr. Vasan, can you please?
Yeah. Good evening, all. Greetings from India, Indian Academy of Pediatrics. Thank you, Vanita, for your really effort. And this is the really sixth webinar. It's going on. It's really needs a passion, dedication, everything. Our National Secretary, Dr. Yogesh Parekh, our past President, Dr. Basavaraja, today's speaker, and all from Bahrain. That's our American Mission Hospital, Bahrain staff, and today's delegate. Once again I welcome you all for this great grand academic event, which is the really exchange program of knowledge from India and in Bahrain, and so many people nowadays from other states also joining. So today really there is a need of the exchange of the knowledge and sharing. And coming to today's topic, that's a pediatric rheumatology. Now, this is really something very interesting topic, which we never thought 10 years before. Now, this type of diseases, actually, uh, frankly speaking, infections are getting less and less. All these only virus remain, and now rheumatology, allergy, these all non-infectious diseases are coming up. And we have to think of all this, and we have to be very perfect knowledge about this. So this is a really great thing that you people have arranged such a Dr. Anand, what to say about his knowledge and everything about rheumatology. Is the boss in pediatric rheumatology, and other speakers also. We are always there for academic event. So there should be exchange and whatsoever help in arranging academic event. Our Dr. Basavaraja is there, Dr. Ranjan is there, Dr. Yogesh is there, Dr. Atanu is there. And so you can always call us, you can take us, and any help if you want, always. So thank you once again, and I wish all the best for the future program. Thank you.
While we proceed, I will make a request to all the participants to please mute themselves and unmute when you are joining the discussion. Can I make a request, because this caused a lot of disturbance in our last session? I would see if we can reiterate it and reciprocate on the same lines here by my side. Thank you, Dr. Vasant. Dr. Yogesh, a few words from you
Yeah.
before.
Yeah. Madam Dr. Basavaraj is there, so few words from them. Then after that, I will speak
I'll-
few lines.
Okay, I will go to Dr. Basuraj.
We have to follow our
A
protocol.
word of introduction about Dr. Basuraj. He has been the president who made this particular collaboration possible. Dr. Ranjan and Dr. Basuraj were the crusaders behind the whole possibility of our collaboration. And we are very glad and grateful to have such a person championing the cause of our CMEs today. So Dr. Basuraj is the president of the year that we inaugurated IAP AMH collaboration. Dr. Basuraj, please, a few words from you.
Thank you very much, Dr. Vanita, and Dr. Muhammad Salaman, Dr. Brahmara Muduri, our team of an IAP Bahrain, which has been going very strong, conducting all the academic program. Our Honorable National President of Indian Academy of Pediatric, Dr. Vasant Kalatkarji, who has been very, very cordial and making the academics to be taken across the border, along with our President-elect, Dr. Neelam Mohanji, is also joined, and Dr. Yogesh Parikh, our Dynamic Secretary, who happens to be there last year in Bahrain to inaugurate this overseas branch. Dr. Atanu Batra, all of them are doing an excellent work with the subspecialties which are emerging. This is way now Indian Academy of Pediatrics to be taken into the greater heights in terms of an equality of academics. The IAP Bahrain branch under the guidance of Dr. Vanita and Dr. Ranjan Pejawar, our international collaboration work is doing in great way. So really, these are the things which has been required. I'm sure all the people who have been joined here is going to be benefited with Anand Rao. I know him for last 20 years. He is an astute clinician and academician par excellence. He will take the rheumatology into the greater heights. Thank you. Thank you.
Thank you, Dr. Basaraj. Dr. Neelam, as ever, she would have her insights and will be very encouraging. She's always been there for all our monthly webinars. Dr. Neelam, can we have you?
Yeah, thank you so much, Vanita and Salman, for the stupendous work that you people have been doing. And it's so nice to be on this podium. And all that I can say is that we are actually at the crossroads of the rapidly developing world. Yesterday, I was in the World Health Summit, which had leaders across the globe, whether it were physician policy makers, organizations like WHO, UNICEF, Bill Gates. All that I realize is, and the theme always is to, how we are able to get equity of healthcare. And the purpose of such deliberations across borders, across zones, is just to ensure that there is meaningful collaboration which results in equity of healthcare. That's what when we exchange knowledge, it's not only about the health challenges, the scientific pursuits, whatever innovations we come across. What I did a decade back is sometimes I feel like laughing what I do today. The way you manage an acute liver failure is totally different. So it's not about an institution, it's not about a country, but together we solve complex issues we face alone. But when we share, we feel we are empowered. There's partnerships, there's knowledge, mutual respect for each other makes this collaboration more meaningful and unites with a vision to ensure that children across the globe get what they deserve and reach the SDG goals. And the 17th SDG goal talks about collaboration. And there we are, maintaining that 17 SDG goal to dream the SDG 3 about the health. And so I would just end up by saying together we build bridges of compassion, innovation, excellence, learning, and so let's work together for a healthier and better future. And I welcome each one of you on this podium and look forward for your ideas in future. I've mentioned to Ranjanji, I think he's looking for a place when I can share on acute liver failure, the current management with my experience of 400 liver failures, which data I'm presenting. So I think hopefully sometime soon I should be able to join you all as a faculty. And today let's hear about rheumatology from experts like Anand and Wafa. So over to Vanita. Best wishes for a rocking show.
Thank you. As always, interesting insights from Dr. Neela. At this juncture, I would like to say, when we started, it was small beginnings. What we intended to do was inform the local practice Bahrain pediatric community. But then I'm proud to say our outreach is across the globe, 400 plus registrations every webinar, and it's really encouraging, and thank you all attendees who have made this possible. Thank you very much, and welcome you all again. Dr. Yogesh, would like to hear your insights also.
Thank you, Dr. Vanita, and heartiest congratulations to the American Mission Hospitals with the collaboration with the Indian Academy of Pediatrics, with our dynamic leaders, Dr. Vasant Kalatar, Dr. Neelam Mohan Madam, Dr. G. Baswaraj, and the team of Dr. Vanita and Dr. Mohammad Salman. So this is the 6th webinar, and we are
Mr.
we are
Saji,
here the
can you
sixth.
mute them all?
Yeah, Shaji, you mute all except the speakers. So this is the 6th webinar, and it is highly means very important and highly recognized across the globe. And the day every every month this webinar is going on with the coordination of our liaison, international liaison, Dr. Ranjan Pejawar, and the super specialty pediatrics series we have. And today the updates in the pediatric rheumatology, and both the speaker, Dr. Anand and Dr. Vafa, will be delivering here. And the more than 200 or sometimes more than 500 delegates are joining on this virtual platform across the globe. And this is the high quality webinars, so people are more interested to join. So, and every time we have to learn something. So thank you very much for your collaboration with the IAP, and whatever we can do for our pediatric practice, we can deliver more and more. So our members, our pediatrician, our PG students, and all are benefited. So thank you, Dr. Vanitha. Over to you, please.
Thank you, Dr. Yogesh. As I was saying, we conceptualized the whole thing with Dr. Ranjan handpicking every speaker across India, which is a mammoth task, which you all can imagine. And we have got all excellent speakers so far. Dr. Leenam, as it happens, the next 6 months will be scheduled with Dr. Ranjan planning the next future 6 sessions, and of course, pediatric gastroenterology. We are foreseeing a talk from you in this session. Thank you, Doctor. Thank you all for your encouragement. Now we go to the actual session. Let's thank you all for kickstarting the event. We will get started. I would like to introduce 2 of eminent pediatric rheumatologists from their part of the world, Dr. Anand Rao from Bangalore, India, and Dr. Wafa Madan from Bahrain. Welcome you both to the session. After we finish the formal introduction, we'll get kickstarted with the topics. Today's topics are Kawasaki disease and juvenile idiopathic arthritis. We will get to hear the latest updates and revisions and the necessities that a pediatrician is essentially supposed to know. And we'll have an interesting co-discussion from the experts as well as the audience. Dr. Anand Rao, can we have you over? Dr. Anand P. Rao is a consultant pediatric rheumatologist from Bangalore, India. He is consulting in Manipal Hospital and Indira Gandhi Institute of Child Health. I would like to mention that I am from IGICH once long ago during Dr. Vanakapa's time. Yeah, Dr. Anand Rao, please join in. He is having a lot of accolades in the field, many publications to his credit, and awards in the same field. I wouldn't be able to list them all. We'll put forth his CV for the benefit of the viewers later. One of which he wanted to be mentioned. He is a pioneer in the field, and he has a discovery of an autoimmune disorder to his credit as well. So we will hear from him more details about all these when we go into the discussion. Today's topic he's going to talk about is updates in Kawasaki disease. All pediatricians assembled over here would have definitely encountered this disease. The challenge here is it remains with same uncertainty that it began years ago, and the same uncertainty puzzles us even today. The other intriguing part, although there have been so many advances, it still depends on good clinical evaluation, and the diagnosis depends on a constellation of symptoms which are grouped into criteria. AHA recently revised, and probably we are supposed to know details regarding this. And we're hoping to hear all that we are supposed to know and getting some more clarity in this mysterious condition. So over to you, Dr. Anand Rao. We are waiting to listen to your CME.
Thank you so much, Dr. Vanita. Let me share my screen. Okay, so I would like to thank IAP, the office bearers of IAP, IAP Bahrain, and American Mission Hospital for having me here. Today, I'll be speaking about the updates of Kawasaki disease. So, what is Kawasaki disease? Before that, you need to know what is a rheumatologist. A rheumatologist is someone who does precision guesswork based on unreliable data provided by those with questionable knowledge. To a great extent, it is true. The only good thing about it is there is a precision guesswork. Clinical medicine, most of the times, is a precision guesswork. It's an art of probability. Many times you need to connect the dots to get to the right diagnosis. And what better disease than Kawasaki disease? So I had this opportunity to meet the great Dr. Tomisaku Kawasaki in 2005 when he was in India for a pediatric rheumatology conference in PGI Chandigarh. This is a story of 20 years ago, and I still treasure this photograph which I have with him. So what is Kawasaki disease? Kawasaki disease is a medium vessel vasculitis. There are only two very important medium vessel vasculitis in pediatric rheumatology. One is polyarteritis nodosa. The other one is a Kawasaki disease. Kawasaki disease was known as also a form of a polyarteritis nodosa earlier until Dr. Tomisaku Kawasaki discovered this disease. So what are these medium vessels? Medium vessels are the blood vessels which supply the various visceral organs. It can range from, say, coronaries in the heart to splanchnic blood vessels which supply the GIT. So when you have involvement of these involve the arteries and the arterioles. And what are the hallmarks of the disease? So you have a very high grade remittent or intermittent fever, which is a classical feature. So you need to have fever for diagnosis of Kawasaki fever of at least 5 days. Unless you have all the other 4 criteria being fulfilled, you at least need a fever of 5 days duration. You need to have a conjunctival congestion. Now, this conjunctival congestion is very unique that it comes with perilimbal sparing. Now, with a very irritable child, it is very difficult to make out, but this photograph beautifully illustrates the limbal sparing, conjunctival congestion without any evidence of exudative conjunctivitis. So this is very important. You can have a classical strawberry tongue. Now, why does a strawberry tongue happen? This happens because there is a subclausal erythema, which happens because of vasculitis. There is a disruption of the filiform papillae, and the fungiform papillae stand out, which gives you a classical strawberry appearance. This is a beautiful description of the same. You can also have cheilitis, which is a lips which crack, which are erythematous initially, which crack. And you can have a rash, which is seen on the face. And most of these kids tend to be very irritable. This irritability is because of aseptic meningitis. And during the subacute or convalescent phase, you can have a skin peeling off, like one of our patients whom we diagnosed on day 9, day 10, on day 13, day 14, started having this skin shedding off. And if you see these patients after 3 to 4 months, they also have nail changes, which are known as Bose lines. This indicates phases of growth arrest, which happen during a catabolic process. It's not only limited to Kawasaki disease, any of the diseases which can cause significant catabolism in the body can cause growth arrest of the nails, which become apparent as the nail grows further. So this only tells you that in the past, this child had a catabolic process. So how does the timeline evolve in a Kawasaki? This is more for people who are new to this field. The fever typically tends to be one of the first symptoms, and it can go on for 2 to 3 weeks. But the median duration of fever is about 12 days. The platelet count doesn't increase very quickly. It usually starts to increase by the end of the first week, peaks by second or third week. So you don't need to have thrombocytosis in the first week itself. So it is not mandatory. It's something which evolves over a period of time. Arthritis tends to pick up by the second or third week. Arthritis is typically seen about 50 to 60% of the patients. The first cardiovascular manifestation, which is myocarditis, many of these children can present with cardiogenic shock. Typically happens in the first 4 to 5 days. And aneurysms, as you can see in this graph, starts happening by second, third, or fourth week, peaks by around 5 to 6 weeks. But it is important to realize absence of aneurysms doesn't rule out Kawasaki disease. The skin changes typically starts with red and swollen palms and soles. The swelling of the palms and the dorsum of the feet is a classical hallmark of Kawasaki disease or any childhood vasculitis, but Kawasaki is a very classical disease wherein you can develop this swelling of the palms and soles. Keep in mind that you can have the swelling of the palms and soles even because of IV extravasation. Make sure that that IV line has not been placed in that limb when they have this swelling. They can develop desquamation. Desquamation, as I said earlier, happens in the second, third week. The nail changes, as I said, takes 4, 5 to 6 weeks to appear. And the lip and mucosal changes typically start happening in about 80 to 90% of patients in the first week itself. That's a direct giveaway. It's very important to look at the throat of any child to look for early changes. You can have conjunctival congestion, which also starts off very early. If you don't have conjunctival congestion, history of conjunctival congestion is also very important because this can be transient, can go on for 2 to 3 days and disappear. Cervical adenitis is a little bit of fickle manifestation of Kawasaki. Typically tends to happen in the 40 to 50% of patients, something which can be easily missed in an irritable child, but it's always worthwhile to gently run your hands on the neck to see if there are tender or non-tender unilateral cervical adenopathy. So coming to the diagnostic criteria, all the features I mentioned, you need to have fever which has been running for 5 days and at least 4 of the following criteria. The first being the mucosal, because it's seen in 90% of the patients, erythema and cracking of lips, strawberry tongue or erythema of the oral or pharyngeal mucosa. If you have bilateral conjunctival injection without exudate, that's another criteria. Rash, which can be polymorphic. It can range from maculopapular to completely diffuse erythema or erythema multiforme like rash. Edema or erythema of the digits, these are peripheral changes, or periangular desquamation in a later stage can also be a very important criteria, and cervical adenopathy of more than 1.5 centimeters, which is usually unilateral. So for a complete Kawasaki, you need to have fever for 5 days with 4 of the described criteria. So when should you think beyond Kawasaki disease? So when you have an exudative conjunctivitis, when you have purulent discharge, when you have an exudative pharyngitis, you have discrete intraoral lesions. It might indicate a viral pharyngitis, something like a adenoviral or a herpes. Bullous or a vesicular rash is a strict no-no for a Kawasaki. You can have any form of rash, but not bullous or erythematous or vesicular rash. If you have generalized lymphadenopathy, think of a different condition. Splenomegaly is very unusual in Kawasaki, and discrete oral lesions, which I already described. So what causes KD? Because this is always a question which our parents do ask, why did my child have Kawasaki disease? There are agent factors and there are host factors. Now, agent factors, this has been long speculated that it is a virus, which we are still getting to know. We still don't know. The reason why they're thinking of it as a virus is because when we were all closeted in our houses during the COVID-19 epidemic, the incidence of Kawasaki declined because the children were not going to school. Interaction between children and adults was significantly low. And the other thing which has always been documented is the presence of a oligoclonal IgA production, wherein you have a IgA which is of a very same class which is seen in Kawasaki disease patients, which indicates that it's a very targeted IgA production against a still unknown virus. But we still don't know what that virus is. A lot of research is going on. Let's hope some results come through and we know what this virus is. Coming to the host factors. Now, it's not everybody who develops will develop a Kawasaki disease. Why do Japanese develop it more often than the rest of the world? Their incidence is about 350 to 400 patients of less than 5 years in a black population is what their incidence of this is, as compared to the Western literature, wherein they say 15 to 20% per lakh population. So it indicates that there is a genetic susceptibility. And many of these genes, like ITPKC, it increases the susceptibility to Kawasaki disease. It also heralds IVIG resistance. And there is a higher risk of a coronary artery aneurysms in patients who have this single nucleotide polymorphism. So why is it relevant? Now, if you have ITPKC, and this can be detected early rather than wait for 3 weeks, it might indicate that these patients are at high risk, and maybe we can use cyclosporin as which it can act as a negative regulator of T cell activation by the calcium NFAT pathway. So it's very important that we work on this line, and if we can get a quick genetic result in a Kawasaki patient, and if it's ITPKC positive, we can use a targeted drug delivery like a cyclosporin. This is the beginning of pharmacogenomics. If you have FCGR2A, it is a receptor for immunoglobulin. Now, if you have a FCGR2A single nucleotide polymorphism, you can develop immune dysregulation, prolonged inflammation, higher cytokine release, and more coronary injury. So it's very important because it also indicates that IVIG resistance in patients who have this polymorphism, and they can have higher coronary artery aneurysms. So what are the cytokines which are active in KD? The interleukin-1 is produced by macrophages. It elaborates significant amount of cytokines, which includes IL-6, IL-17, and TNF-alpha. It also induces endothelial dysfunction, leukocyte adhesion, and vascular leakage. and it causes coronary vasculitis. So it's very important to keep in mind in a refractory Kawasaki disease, IL-1 antagonists like anakinra can be used when they fail the other known drugs which are used in Kawasaki, which is Kawasaki disease, which is IVIG refractory. Another cytokine which has recently made headlines in Kawasaki disease is IL-17, which is produced by T helper 17 cells, which is a CD4 subtype. And it's a bridge between the innate and adaptive immunity. And in Kawasaki disease patients who have coronary artery aneurysms, it has been noted that the three subtypes, 17A, 17C, and 17F, are elevated. Now, why does this become important? Is because you can use now anti-IL-17 therapies are being marketed for other conditions. In a refractory KD, it might be useful to consider using anti-IL-17 therapies to prevent worsening of the coronary artery aneurysms or to prevent it in those patients who are refractory to therapy. How do coronaries get involved? What is the pathology? So there are three stages, which was brought about by this beautiful paper by Shulben et al., wherein they did an autopsy of those patients who had died because of a Kawasaki disease associated coronary artery aneurysms. It was noted that in the first 2 weeks, you tend to develop uh, necrotizing arthritis. Now, this necrotizing arthritis has neutrophilic infiltration. The innate immune system starts kicking in, and neutrophils are one of the first cells which enter the intima and media and start elaborating cytokines, and direct destruction of intima and media happens. When you have a direct destruction of intima and media, the coronaries can rupture. So rupture typically happens in the first month, and this rupture can lead to myocardial infarction. And you can have thrombosis also because it's an inflamed endothelium and which can aggregate platelets. That's the reason why we use platelets in anti-aggregate antiplatelet. We use aspirin as antiplatelet drug early on to prevent this thrombosis. And thrombosis can organize and recanalize and calcify, which can lead to progressive ischemia or myocardial infarction in young. So it is very important to realize these stages because the pathology or pathogenesis tells us why we are using these therapies at different stages. Stage 2 is when the disease goes on for months to years. Here you have subacute chronic arthritis. The neutrophils are replaced by lymphocytes, eosinophils, plasma cells. And these cells start increasing the extracellular matrix. The aneurysm can worsen. You can have the stenosis setting in because you have cells which will lead to production of fibrous replacement of the intima and media, and that can lead to progressive ischemia and myocardial infarction. You can have thrombosis also. In stage 1, you typically tend to have a saccular dilatation. In stage 2, fusiform dilatation comes in. Stage 3 is something which sets in after the first 4 weeks, and it can go on for years. Now, what is this stage? This is luminal myofibroblast proliferation. And an inflamed coronary, subsequently, after the inflammation has settled down, smooth muscle transition to myofibroblasts happen, and these go on proliferating. And these proliferation of this myofibroblasts, as you can see, will lead to luminal narrowing. And this luminal narrowing causes, once again, depletion of the blood supply to the myocardium, and it can lead to myocardial infarction months and years after the disease onset. Coming to case 1, a 2-month-old infant was brought in with history of febrile illness of 4 days, presented with respiratory distress and cold clammy extremities to the emergency room. The child was tachycardic, tachypneic. There was fullness of the dorsum of the hands and feet. Gallop rhythm was noted. Chest X-ray showed a right paracardiac haziness, and as is expected, it was diagnosed as pneumonia with sepsis and started with antibiotics. The labs revealed anemia, leukocytosis, borderline thrombocytopenia, elevated CRP, and pyuria. So there are many features which are suggesting that it is not a single organ system involvement. There seem to be some hematological involvement. There is some pyuria in the urine. The child stabilized with fluids and antibiotics, but the child continued to be febrile. On day 8, it was seen that the anemia was worsening, counts were still increasing. Platelet counts, which were 1 lakh, had gradually started creeping up to 7.5 lakhs. CRP was still climbing up. The intensivists were very worried. So when should you think of a Kawasaki disease in a febrile infant? Less than 1 year, or more importantly, less than 6 months. It's important to think of Kawasaki disease in any child with an infant with a fever of more than 7 days. Prolonged fever and irritability is a clue to the diagnosis of Kawasaki disease. Aseptic meningitis with prolonged fever, wherein you have a child with features of aseptic meningitis, irritability, but is not getting better with antibiotics. Culture negative shock. When you have prolonged febrile lymphadenitis or any abscess, especially the retropharyngeal or parapharyngeal abscess with a prolonged febrile illness, keep in mind of Kawasaki disease apart from a culture negative UTI in an infant. So what tests would you order in a setting like this? Keep in mind, many of these children tend to have incomplete forms, like our child. So it's important to, when we have an incomplete Kawasaki disease, in any child of more than 1, with fever of more than 5 days, with 2 or 3 compatible features, or infant more than 7 days without focus, always check the CRP and ESR. If CRP is more than 3 mg/% or ESR is more than 40 mm/hour, then you go to the next step, wherein you ask for the CBC, LFT, and urine routine. And also ask for a 2DI code to look for features of Kawasaki disease. What did our child have? Our child had anemia, thrombocytosis, hypoalbuminemia, leukocytosis, and pyuria. So the features were classical. They were fulfilling the 3 criteria, and it is important to treat these patients. So when is a 2D echo suggestive? Always keep in mind that a Z-score of more than 2.5 in left anterior descending coronary artery or right coronary artery is sufficient to diagnose a Kawasaki disease. If you have a coronary artery aneurysm of any size, then it is a diagnosis which is made. But if you have a dilatation, that is Z-scores of 2 to 2.5, you at least need to have 2 of the other 3 being present to make a diagnosis of Kawasaki disease, which are decreased ejection fraction, mitral regurgitation, or pericardial effusion. So I'll show you a couple of videos showing coronary artery aneurysm. This is a left coronary artery aneurysm. You can see that there is a complete, when you inject a dye, you see that there's a dilatation, and beyond that is the left coronary artery. So this is something which is very classical of a missed or a delayed diagnosis of coronary artery of Kawasaki disease. Another image which is showing a right coronary artery involvement. As you can see, it is not a single aneurysm. There are 3 to 4 of them. If you can see, there is 1, 2, 3 here, 1, 2, and 3, and this is a large one. So this is a right coronary artery aneurysm, which is seen on the coronary cath. So it's important to keep this in mind. So what are the updates on therapeutics in Kawasaki disease? So if I draw a timeline of Kawasaki disease, after the first description of 1967 by Dr. Tomisako Kawasaki, IVIG came into the picture in 1983, wherein Purusho, based on the response of idiopathic thrombocytopenic purpura, suggested that why not use IVIG in Kawasaki disease too, because it's also an immune-mediated reaction for lack of any better drug. So how does IVIG act in Kawasaki disease? IVIG has multiple roles. The most important are there is induction of lymphocyte apoptosis. Now, lymphocytes drive the latter part of the disease. Increases the T regulatory cells. T regulatory cells dampen the inflammatory response. So when you have upregulation of T regulatory cells, it calms down the inflammation, brings order to the inflammation in the coronaries and systemically too, and decreases the production of intracellular IL-1 beta in the neutrophils. Now, this is also an important part wherein IVIG scores over the rest of the therapies. But what are the adverse effects? When you give IVIG at 2 grams per kg, it can sometimes lead to aseptic meningitis. It can lead to hemolytic anemia. The hemolytic anemia is more common when you give the second dose of IVIG. And there have been instances of hepatitis C transmission way back in 1994. Now, with better modes of transmission and prevention of transmission of bloodborne pathogens, the third risk has been somewhat ameliorated. Does the dose of IVIG matter? In ITP, they used to use 400 mg for 5 days. Subsequently, trials have shown at 2 gram per kg, given as an IV infusion, as a single IV infusion, works better than the doses spread over 5 days. And aspirin alone, the coronaries which were noted at day 30 and day 60 range from 26 to 18%. But as you can see, the increasing dose of IVIG from 1 gram to 2 gram, there has been significant reduction of coronary arteries aneurysms to 4% at 30 and 60 days. So from 25-26%, the aneurysms have dropped down to 4% with use of aspirin with IVIG. Aspirin dose didn't matter, but IVIG dose definitely mattered. But about 2 grams, it is not suggested because of the fluid shifts which happen because of IVIG use. And the other thing which can happen is the side effects associated with IVIG. Aspirin, though it is one of those grand old drugs of Kawasaki disease. Initially, they used to use much higher dose. The use of aspirin came in because of its use in other inflammatory conditions. So it was one of the first anti-inflammatory drugs. It was used at 80 to 100 mg per kg per day. Subsequent trials have shown that 30 to 50 mg per kg per day is non-inferior to 80 to 100 mg per kg per day and decreases the side effects associated with aspirin. There has been a study done in Canada wherein they have shown even use of 3 to 5 mg per kg per day is as good as 30 to 50 mg per kg per day, because more than the anti-inflammatory effect of the aspirin, it is the antiplatelet effect which becomes more important. And there has been no effect on the prevention of coronary artery aneurysms. I wouldn't be surprised at a point in time wherein we might go off aspirin as time passes by. The adverse effects of aspirin include elevated transaminases, transient hearing loss, hemolytic anemias, and Ray's syndrome, which can be associated with influenza or varicella. Coming to another interesting case, which we encountered about 5 to 6, 7 years ago, a 2-year-old was brought with complaints of febrile illness of 9 days with redness of eyes since the past 2 days prior to admission. So the child was febrile irritable. He had non-purulent conjunctivitis, periangular desquamation, erythematous maculopapular rashes. So there were 3 criteria being fulfilled. We had to go further and evaluate. When we did that, we found that there are hypoalbuminemia being present with leukocytosis. But 2D echo, which was done, revealed dilatation of the left MCA. And we diagnosed it as incomplete Kawasaki disease based on the 2D echo with other the corroborative evidence. We started on the standard protocol of IVIG 2 gram per kg with 50 mg of per kg of aspirin. The child persisted to have fever, worsening of Z-scores. Second dose of IVIG is given. There's persistent fever. After 3 days of the second dose of IVIG2, we had to give him infliximab at 5 mg per kg. Fever persisted, Z-scores didn't get better. We had to pulse him with IV methylpred for 3 days on 22nd of June. Fever continuing, not getting better. He was on oral aspirin. The second dose of infliximab was given on 28th of June. After remaining afebrile, fever returns. Echo reveals aneurysms which are persistently worsening. cyclosporin A was started based on trial which happened in 2016 in Japan. Beta blockers, statins, and low molecular weight heparin was started. Finally, he becomes afebrile. If you look at the labs, he has worsening anemia, persistent leukocytosis, thrombocytosis at the fag end after second week of illness, and you see that NT-proBNP was mildly elevated. So this is the graph showing there has been a persistent worsening of the right coronary artery in spite of being treated with 2 doses of IVIG infliximab. Though the other coronaries also took a hit. As time passed by, we added on cyclosporin A in the 3rd week, and subsequently what we noticed is gradually the steroids were tapered and stopped in 2 months after the disease onset. Cyclosporin also tapered and stopped in the 3rd month. And we continued anticoagulant therapy with warfarin, beta blockers were stopped, and child has been continued. So we can have roughly about 20 to 30% of patients who are IVIG resistant. The Japanese have their own IVIG resistant anticipation scores, wherein you directly, when the patient comes to you, you diagnose them as IVIG resistance based on a few scores, which includes Kobayashi, Igami, and Sano. The problem with these scores is these scores are good for the Japanese population, but haven't shown the same sensitivity or specificity. They don't have too much of a positive predictive value. They have greater negative predictive value as compared to the positive predictive value. So coming to the North American scores, which are the best we can go by, a score of more is 3 is considered. So 2 points is given to enlarged coronaries if you have an echo which shows a baseline z-scores of more than 2. Age less than 6 is given a score of 1. Any Asian race, including ours or be it in Bahrain, is given a score of 1. If the CRP is more than 13, it's also given a score of 1. So in view of lack of any scores for the South Asian population, maybe we can use this to predict IVIG resistance. So when you have IVIG resistance, primary intensification has been advised. Now, you can start with IVIG with aspirin, but you might either use IV methylprednisolone at 2 mg per kg in 2 divided doses, followed by oral prednisolone for 2 to 3 weeks. Infliximab, given at 10 mg per kg as an IV infusion, can also be considered as primary therapy when you are anticipating IVIG resistance. So, prednisolone, how did it come into the picture? Now, steroids started off as the bad guy in the management of IVIG based on one of the studies done by Dr. Cato et al. In 1979. Now, this was because of a poorly designed study without a proper dose criteria. And there were no scores which were available, and every child was treated with steroids with aspirin. And they found that those patients who were treated with steroids, 64 of them, or 64% of them had coronary artery aneurysm. 3 decades passed wherein the KD experts said strict no to use of steroids. But the first and the second decade of 2000s changed that. The 21st century, the most important trial which happened was the RAISE trial in 2012 by Dr. Kobayashi, wherein they used oral steroids, IV steroids followed by oral steroids at 2 mg per kg in those patients who are at high risk of developing IVIG resistance. And they found that the chances of having a IVIG, the coronary artery aneurysms in these patients dropped in those patients who were given steroids was only 3% as compared to 23% who were not given steroids or only given standard therapy. So that opened that made steroid a good man once again in treatment of Kawasaki disease. So it can be used as an adjunct therapy to IVIG and aspirin upfront in those patients who are at risk. Can be used as rescue therapy in refractory Kawasaki disease. Dose can range from 2 mg to 30 mg per kg. We tend to use 2 mg per kg per day. Duration of treatment is for 2 to 3 weeks. CRP can be used as a marker to titrate the dose, and you can use that dose for 3 to 4 weeks until normalization of CRP happens. The second drug which came in has been use of infliximab. Infliximab is useful in IVIG refractory KD patients. It targets TNF-alpha, which is one of the drugs, one of the molecules which mediates inflammation. 10 mg per kg has been found to be better than 5 mg per kg. Rapid mode of action. It is useful in those patients who have significant inflammation, presence of shock. It helps control the inflammation in the system, in the systemic circulation. But unfortunately, the KitCare trial, which was done in 2020-21, which was published in 2021, didn't reveal coronary artery aneurysm amelioration. So it helps control the systemic features. It helps curb the hospitalization, number of days of hospitalization, but doesn't curb or doesn't decrease the coronary artery aneurysm risk, or doesn't help decrease the coronary artery aneurysm. So there's always a search for new drugs, and cyclosporin, they did a trial in 2016. It's a calcineurin inhibitor, blocks T cell activation, decreases the T cell in the circulation, given as 5 mg per kg per day in 2 divided doses. And what we use in our routine clinical scenario is we follow it up with watching for inflammatory parameters and echo, and we normally tend to continue it for 2 to 3 months. The trial which was then done in Japan, the KaiCart trial in 2016, mentioned use of cyclosporin only for 5 days, but that was too short a period to assess an improvement. We tend to use it for much longer, as I showed it in our cases. Carry of messages. Kawasaki is one of the commonest pediatric vasculitis. Though the course is acute, sequelae can be lifelong. Early recognition and treatment is of paramount importance. Kawasaki disease in an infant is associated with a higher chance of coronary artery aneurysms. Treatment armamentarium is an evolving phase. So it is still developing. There will be a lot of new drugs which will come in to control and prevent coronary artery aneurysms. Those with coronary artery aneurysms would require lifelong follow-up. So this is the road to the Himalayas, which I took a year ago. This also signifies the road which you are taking. It's in treatment of Kawasaki disease. It has a lot of boulders, lot of hills, lot of mountains, but we need to traverse the path. Thank you so much.
Thank you, Dr. Anand. That was a very interesting overview with case examples. It will be interesting to have case discussions after the next presentation, and looking forward for it. We will join you after the next presentation for a discussion. Thank you very much. We shift focus to yet another complex rheumatology condition we all encounter as pediatricians. That is juvenile idiopathic arthritis. Yet again, it is intriguing to pediatricians because it perplexes us with the same uncertainties as well as heterogeneity. So inviting Dr. Wafa. Dr. Wafa Madan, can we have you over to join us? Dr. Wafa Madan is a pediatric rheumatologist.
Am I audible?
Welcome, doctor. Yes,
Yeah.
you're audible. Welcome, Dr. Wafa Madan. We are meeting for the first time. Let me introduce you to the fellow speaker. Dr. Wafa Madan is a pediatric rheumatologist from Bahrain. She is a consultant pediatric rheumatologist in Salmania Medical College, which is a national hospital in Bahrain. She is having many publications to her credit and awards. We will discuss that in detail after we finish the CME. And here she is to deliver content on juvenile idiopathic arthritis. We welcome you, Dr. Wafa. Please take over and get started with our CME, please. Thank you.
Thank you. Good afternoon, and thank you for your kind invitation. It's a pleasure to participate in this webinar. And I will start sharing my slides. So are my slides audible, visual?
Yes,
Can you
doctor.
see my slides?
Yes, doctor.
Okay.
You can proceed.
Start. Okay, good afternoon, and it's my pleasure to participate in this webinar. So the topic today will be about juvenile idiopathic arthritis. It's very subspecialized topic, so it's very long presentation, but I'll try to summarize it and try to highlight the important relevance to practicing a pediatrician. So try to cover the definition of juvenile idiopathic arthritis, the ELAR classification, clinical spectrum of it, the need for uveitis screening, complications, available treatment, hopefully outcome and prognosis. So the first message, hello? Yes. So the first thing I'd like just to highlight that joint problems in children doesn't mean always juvenile arthritis. From the table, you see there are many differential diagnoses of joint pain or joint problems in children. One of them is arthritis, whether acute or chronic. Other differential could be degenerative causes related to hypermobility, slipped upper femoral epiphysis, or other orthopedic issues. It could be pain syndromes or simply infection, tumor, malignancies, or even genetic problems like skeletal dysplasia. So you see, juvenile idiopathic arthritis is only one of the differential of arthritis, which is could be a cause of joint problems in children. So what is the definition of juvenile idiopathic arthritis? Juvenile idiopathic arthritis is a chronic arthritis that persists for minimum of 6 consecutive weeks in one or more joints. It should commence, it said juvenile, so from the name, it should usually commence in juvenile age below 16 years and after exclusion of other medical condition or causes that could be attributed to the arthritis. So here, just to highlight, hello?
Yes, doctor. Please
Yeah,
continue.
you can see the slides, right?
Yes,
Because
doctor, yeah.
I don't see them very well. Okay, so this is just to highlight the normal knee joint. I'm sure all of you know the anatomy. And how does the osteoarthritis joints, it's wear and tear, and the juvenile arthritis or rheumatoid arthritis in adults, you see inflammatory process affecting the synovial fluid with redness, swelling, and effusion that, if uncontrolled, ultimately will lead to damage of the articular cartilages. As you know, juvenile idiopathic arthritis is an autoimmune disease. Nobody knows what's the trigger, but there is infiltration of inflammatory cells in susceptible children, and there is a trigger. We don't know what is it. Environmental trigger, probably virus, but no clear identified viruses for this. So it's an interplay between genes in susceptible children, infection, viruses, or other trigger, and immunity. How is your immune system react to this stimuli? So how common is juvenile idiopathic arthritis? Is the most common chronic rheumatological disease of childhood, with a prevalence of 1 in 1,000 children, with a variability based on the ethnic background, most frequent in Caucasian patients and rarer among African population. There are many classifications for juvenile idiopathic arthritis. It used to be till mid-1980s to be called juvenile rheumatoid arthritis in US, and in Europe and elsewhere used to be called juvenile chronic arthritis. However, the ELAR, International League for Association for Rheumatology, it tried to classify it in a more accurate form, and this classification advanced the term juvenile idiopathic arthritis to refer to these idiopathic disorder. So in other terms, juvenile idiopathic arthritis is not one disease. It's a collective term of clinical patterns of arthritis of unknown cause in children, which fulfill the definition that I described earlier. Why do we say it's a collective terms? Because as you will see in this slide, ELAR classification based on the mode of presentation or mode of onset during the first 6 months of disease onset, you have many subtypes like systemic onset, persistent oligoarthritis, extended oligoarthritis, polyarthritis, RF negative, RF positive, enthesitis-related arthritis. Under this category, you have ankylosing spondylitis, IBD-related arthritis, Reiter syndrome, psoriatic arthritis, or undifferentiated arthritis. We'll come in more closely to these definitions or more details. But we don't like to complicate things in pediatric rheumatology, but really these classifications and subtypes, it doesn't have only implication in research. It has very important implication in clinical practice, the prediction for prognosis, how aggressive in your management. So coming to class by class, so the first class, I'll start with the most common class that we encounter in pediatrics is the oligoarticular GIA. Oligo means it's affecting 1 to 4 joints at 6 months of disease onset. We say it's persistent if remain to be 1 to 4 in the first 6 months of disease onset, and we call it extended if it's go beyond more than 4 joints after the 6 months of disease onset, and it will be similar to RF poly-GIA. This subtype is the most common, accounting for more than 50% of juvenile idiopathic arthritis, typically affecting young girls with predominance of females, usually below 6 years, toddlers, usually 2 to 3 years, with a gradual onset. Common presentation that they will appear to your clinic with abnormal gait, limping. There is no reports of pain. You will just examine these children and you will see the swollen knee joint, which is effusion, without reports of pain. This subtype usually is asymmetrical. As I mentioned earlier, the knee is the most common joint to be involved. The hip never or very rarely to occur, and small joints usually not typical. So if you see hip joint involvement, TMJ involvement, even if it is 1 to 4 joints in the first 6 months of disease onset, always keep in mind that probably it will not be persistent oligoarthritis. Probably it will progress to extended oligoarthritis, which is similar to poly-GIA. Usually you will have normal inflammatory markers, and so that's why you will not rely on the labs to decide is this juvenile arthritis or not, because more than 50% of the cases, which is oligoarticular, will be normal inflammatory markers. The main risk for this category is the risk of leg length discrepancy if the arthritis, small arthritis going on for a long time and undiagnosed, and the risk of uveitis, which is usually asymptomatic and sight-threatening. Coming to the next subtype is polyarticular GIA. It's the next common. It accounts for 25% of juvenile idiopathic arthritis with a female predominance. Among it, there is RF negative and RF positive. When I say poly, that's mean in the first 6 months of disease onset, the joint affected is 5 or more joints. Usually the RF negative, that's mean RF will be negative, is more common than RF positive. And the RF negative, it has 2 early peaks, early peak at 2 to 4 years and another peak 6 to 12 years. The poly RF positive is less common. It's and as the name suggests, it has positive RF, which need to be confirmed in 2 occasions 3 months apart. And this is a great mimicker for rheumatoid arthritis in adults. It's usually happening late childhood or adolescent in female. And from now, that's why we can't call the arthritis in children, the autoimmune chronic arthritis, as rheumatoid arthritis, because as you saw, only around 5% of all juvenile idiopathic arthritis will be RF positive. So it's more accurate to call it juvenile idiopathic arthritis rather than juvenile rheumatoid arthritis. Again, to the poly-GIA, so as you see here, it could commonly affect the joint, which leads to a temporomandibular joint, leading to micrognathia. If going on for a long time, it could affect even the cervical spine. You see the posture of this child is not normal, with deformities in the elbows and the legs. It's usually symmetrical, large and small joint involvement, and hip involvement is common. C-spine, as I mentioned earlier, commonly affected, and TMJ joint leading to micrognathia and small chin as seen in this boy. As you will expect, because many joint involvement, so there will be elevated ESR, CRP, leukocytosis. You could find a vasculitic phenomenon with gangrene and vasculitic rash at the tips of the digits. You could find rheumatoid nodules here, which is usually happening only in RF positive. And you could have, because of extensive joint involvement, as you see here, is muscle wasting from the chronicity and the multiple small joint involvement of the hand. As I mentioned earlier, RF positive, they will behave like rheumatoid arthritis with poor prognosis and very extensive aggressive disease. Still, you have a risk of uveitis, but less frequent compared to the previous subtype. Now, coming to a very unique subtype of juvenile arthritis, systemic onset juvenile arthritis. This is less common, 10%, with a range for 4 to 17%, with equal female and male incidence. It happens at any age, but mostly toddlers 1 to 6 years. And usually in adults, they call it Still's disease. This is very unique subtype of juvenile arthritis, and even now the many experts, they feel it should be considered separate from juvenile arthritis. It is more of innate immunity, autoinflammatory disease, great mimicker for umbrella of rheumatology we call autoinflammatory disorders. How do we define this disease? It is defined as arthritis in 1 or more joints, with 2 weeks of fever, with at least 3 days of quotidian pattern. Quotidian pattern, as seen here, that's mean 1 spike per day with a return to the normal temperature or below the baseline. And this is very characteristic for systemic GIA. But mostly this pattern, usually not seen initially with the onset of the fever, usually it develops later on. So to fulfill the definition of systemic GIA, you need only 3 days of quotidian fever. So again, the definition is arthritis or arthalgia, 2 weeks of fever, plus 1 or more of the following, which are evanescent erythematous salmon pink rash, as you see here, generalized lymphadenopathy, hepato, and or splenomegaly. And after exclusion of more common disease. So it's a diagnosis of exclusion. It is challenging diagnosis. From definition, you can see we are aware of more common causes that lead to similar presentation, top on the list, infections and malignancy. So in many centers, we don't label this unless we exclude common infectious causes and we exclude leukemia, because it's more common and more mimicker than than systemic onset juvenile idiopathic arthritis. And if you know the definition, you don't need 6 weeks of arthritis. You need just 2 weeks of fever and fulfilling the rest of the criteria. On examination, the child will be very sick, toxic, febrile. You could find hepatosplenomegaly, lymphadenopathy, serositis, pericarditis, abdominal pain. On labs, you could find anemia, transaminitis, dramatic elevation of acute phase reactant, and typically they will be seronegative, ANA negative and RF negative. So it is a diagnostic challenge, and after excluding malignancy and infection. It's often refractory to treatment, steroid dependent. So when you suspect that, you will see the antibiotic, usually the child will not respond to antibiotic, and the bone marrow usually will be negative. And if you start in this subtype, you have to start steroid because it's very life-threatening. It could lead to complication called cytokine storm or macrophage syndrome. As I mentioned, it's IL-1 driven, characteristic of autoinflammatory disorders and periodic fever syndrome, and you need to have pulse therapy in addition to the other medications that I will mention later. So MAS, or macrophage activation syndrome, is actually HLH secondary to rheumatology disease, commonly systemic juvenile arthritis. It's life-threatening, it's rare, but it has high morbidity and mortality. Nobody knows why it's happening. Some assumptions that it could be related to NSAIDs or abrupt change in medication, but sometimes it's the initial presentation of systemic juvenile arthritis. You will have hepatic failure, consumptive coagulopathy, anemia, leukopenia, thrombocytopenia, dramatic raised inflammatory marker. The ferritin characteristically very high, 10,000, 100,000, coagulopathy, and we need to manage these patients aggressively with supportive care, pulse therapy, cyclosporine, IL-1 blockade, which is anakinra. Coming to the next subtype of juvenile arthritis, enthesitis-related arthritis. So what is enthesitis? Before I go to the definition of enthesitis-related arthritis, inflammation of attachment of tendon, ligament, fascia, or capsule to bones. And you could find it on examination on the patella at 2, 6, and 10, in Achilles tendon, or on the plantar fascia, insertion of plantar fascia into calcaneus, head of 1st to 5th metatarsal, and the base of the 5th metatarsals. So enthesitis could happen in isolation, but sometimes it's happened in the context of enthesitis-related arthritis, which is a subtype accounting for 1 to 11% of the cases of juvenile arthritis. So either you have arthritis and enthesitis, as the definition suggests, or you could have one of them and two of the following, which are sacroiliac tenderness, inflammatory lumbosacral pain, HLA-B27, arthritis in a male above 6 years, acute anterior uveitis, or history of spondyloarthritis. It has again 2 peaks, early peak 2 to 4 years and late peak of 6 to 12 years, and most commonly in boys. So it shows the Achilles tendonitis on this leg, and this is usually in children, we start with peripheral arthritis, then axial involvement of the sacroiliac joint, and the spine will follow. So here it's very late changes in the sacroiliac joint, and this is reduced forward spine flexion or a positive Schober's sign, as a manifestation of axial involvement in enthesitis-related arthritis, which is similar to ankylosing spondylitis in adults. So the unique complication about ERA is the uveitis. We have it in all categories, but in this subtype, it's usually acute. It's happening 20% acute. It is symptomatic. The patient will present with painful, photophobic eyes and will need eye checkup and treatment accordingly. Arthritis could happen, but mainly in adults, and amyloidosis is very rare. Coming to the next subtype is psoriatic arthritis. Psoriatic arthritis, as the name suggests, it's inflammatory arthritis beginning before the age of 16, and it is associated with psoriasis. So the diagnostic criteria, either you have arthritis and psoriasis, which is usually not easy and mostly doesn't happen at the same time. You could have either arthritis followed by psoriasis or the other way around. But sometimes you have arthritis and at least 2 of the following, which fulfill the definition of psoriatic arthritis without the presence of psoriatic rash per se. So if you have arthritis and at least 2 of dactylitis, which is swollen sausage-like digits, nail pitting, family history of psoriasis in the first degree relative, this will fulfill the criteria of psoriatic arthritis. And it's a must in this classification that it is RF negative. If you see RF positive, that will exclude psoriatic arthritis, but ANA positivity is common. The last sub-classification of GIA is undifferentiated arthritis, which means it's undifferentiated. Either it fulfills criteria in none of the above categories I mentioned, or fulfill criteria for more than one of the above categories, and it accounts for 11 to 20% of all cases. So this is a summary for all the subtypes that I just clarified. So you see, it's a clinical pattern of many diseases, the juvenile arthritis. Now coming to a very unique complication in juvenile idiopathic arthritis, which is uveitis. It's the most common extra-articular manifestation with a prevalence overall of 10–20%, and might precede arthritis in 10%. It's mostly asymptomatic, which is chronic anterior uveitis, which make it very challenging because the child will not present with any signs, and hence the need for urgent referral for eye checkup in any new case of juvenile arthritis, because we can't rely on the symptoms. Only 25% is symptomatic, and this is in the case of enthesitis-related arthritis. There are, overall, it's 10 to 20% of prevalence, but it's more prevalent or more risky, or you will suspect it more common in some risk factors, which is oligoarticular GIA. This is mostly, it's there, and RF negative, psoriatic, or undifferentiated. It's very, very rare in systemic onset juvenile arthritis to find chronic anterior uveitis, which is asymptomatic. It's more common in females, and if very young female below 6 years of age. ANA positive is a marker. If it's positive, this increases the risk of asymptomatic uveitis, chronic uveitis, and it's mostly prevalent in the 4 years of disease onset. But it doesn't mean after 4 years of disease onset, you don't need to screen them. Actually, these risk factors are meant to be kept to decide upon the frequency of slit lamp examination for uveitis screening. The more risk factors you have, the more frequent, up to 3 monthly eye checkups for uveitis screening is there. Why we need to screen for uveitis? Because it's asymptomatic and it's sight-threatening complication if not detected and treated in the right time. So slit lamp examination is vital in the management of juvenile arthritis. There are many guidelines, one of them Protege Society guidelines for uveitis screening. As I mentioned, ideally urgent referral in the first case of diagnosis of juvenile arthritis, and the frequency of screening will be judged based on the risk factors. Now, why we need to treat juvenile arthritis? Because, as I mentioned, there are many complications. One of them is uveitis. The others are growth retardation, so short stature because of the disease, osteoporosis, even without steroids, the arthritis itself, there is a risk of osteopenia and osteoporosis, and limb length discrepancy, especially if you have only monoarthritis, life-threatening conditions like mass and systemic arthritis. And apart from these physical things, also you could have also social, psychosocial problem, low self-esteem, and missed schools. So we really need to manage juvenile arthritis because it's a chronic disease leading to very serious complications. Coming to the goals of GIA management, so we need to have pain relief, suppression of inflammation, achievement of remission. We need to maintain function and mobility of joints to live as normal life as possible with prevent of long-term damage and possible disease-related complication, include extra-articular complications, And we need to facilitate normal growth and psychosocial development and prevent short stature. And all these goals need to be accomplished with minimal toxicity and risk of adverse effects of medication. So this is the goals of juvenile idiopathic management. And this, I'm sure all of you are aware, it won't be accomplished with only the pediatric rheumatologist. It's MDT input with input of ophthalmologists, physiotherapists, occupational therapists, psychologists, social worker, dietitian, nurse, and dentist. So management of juvenile arthritis is not only pharmacological treatment, it's also adjuvant therapy, many subspecialties. So pharmacological treatment is only one part of it. We need to aid it with eye checkup, psychology, physiotherapy, hydrotherapy. All these will complement each other. And always we should keep the family on board. We share the plan of management and we need to consult them. We need to educate the parents. And it's always a process of sharing the options of treatment and keeping the family members on board for the most suitable treatment. Now, when it comes to the pharmacological management of juvenile arthritis, there is two trends in management, which is a window of opportunity and treat to target. Window of opportunity means that we have to give early and aggressive treatment to switch off the immune or inflammatory process as quick as possible, because through studies, this will lead to much better prognosis and less joint damage. Treat to target means even if we started to initiate aggressive treatment, our target and the target of juvenile arthritis is remission. Remission means inactive joint. That means no any activity of arthritis. And thankfully, we have a lot of assessment tools for disease activity to monitor the clinical response for our treatment. There are many, which is beyond the scope of this lecture, like JADAs, ACRs, and many tools to assess the response and to monitor the progress of the patient. There are many pharmacological patients. I'm sure you are aware of NSAIDs, steroids, conventional synthetic DMARDs, methotrexate, leflunomide, biologic immunomodulators, and over the last few years, targeted synthetic DMARDs, which are the JAK inhibitors. Due to the sake of time, I'll just go roughly. NSAIDs as a monotherapy very favored nowadays, and it's old school fashion. Usually we use them mainly as adjuvant therapy rather than as monotherapy. Intra-articular steroid injections, usually it has quick response and it has some side effects. What are the indications for them? They are the gold standard treatment for oligojuvenile arthritis, especially if there is only one or two joints, but in the absence of poor prognostic factors, which I'll mention them later. It's bridge therapy in poly-GIA, because even if you administer DMARDs, it will take time for it to kick in. So we use it as a bridge therapy. And sometimes if you have very well-controlled disease on maintenance medication, you need to mop up residual flaring joints. So the intra-articular injections in this regard will be very helpful. Nowadays, the systemic corticosteroids we know they are very powerful, potent anti-inflammatory drugs, but their usage is limited because numerous side effects and low efficacy in prevention of joint destruction. And I'm sure all of you are aware about the side effect of steroid. So we know it's very helpful, but we try our best as a rheumatologist to minimize the use of systemic steroid, whether oral or IV. However, some indications among the GIA subtypes make us forced, or we have to use systemic steroid. What are these? As you would expect, unremitting fever and systemic GIA. Systemic GIA is very risky and very toxic and very life-threatening situation. In this case, we have to use pulse therapy. And if it's complicated poly-GIA or systemic with systemic complication like myocarditis, pericarditis, pneumonitis, hepatitis, or if we are having poly-GIA with extensive joint involvement, many joints that we can't keep any physiotherapy program for them. And so we have to help the pain issue with systemic steroid to help them to cooperate for intensive physiotherapy and rehabilitation program, pending the action of the maintenance treatment that I will mention later. Now, the DMARDs, I'm sure all of you know about methotrexate and the others, leflunomide, sulfasalazine, hydroxychloroquine, and cyclosporine. Methotrexate is the traditional gold standard in juvenile arthritis and the first choice and considered to be the safest, most efficient, and least toxic of currently available DMARDs. What is the indication for methotrexate as a DMARD in poly-GIA or psoriatic arthritis, peripheral psoriatic arthritis? Usually, it's the first line of choice. So whenever you diagnose a child with poly-GIA, we need to start on methotrexate, but pending the action, we need to give bridge therapy like steroid injection or systemic steroid. Oligo-GIA, as I mentioned, usually steroid injection, localized injection is the treatment. However, if there is poor prognostic factors at diagnosis, which are ankle, wrist, hip, TMJ joint involvement, or raised inflammatory marker, or symmetric arthritis, or evidence prolonged disease activity at diagnosis, this will mention that this is not simple oligo-GIA. Probably it will extend further to extended oligo or poly. That's why we need to be aggressive from the beginning, and injection is not enough in this case scenarios. Sometimes you have to inject many times the same joint. Usually, if you reach 3 injections per joint per year, this is indication to advance the treatment to methotrexate. Methotrexate is also used as a treatment for uveitis, which is not adequately controlled with topical steroid drops. I'll skip so the dose, and this is very technical. I know I think I'm a little bit running out of time. So the dose is 10 to 15 mg, oral, sub-Q, or IM. And it's very important to remember the response will take minimum 8 weeks to act. So that's why sometimes we need to use the steroids as a bridge therapy. So the efficacy of methotrexate is 60% and remission in 50% after 1 year, but it has many side effects like nausea, like liver derangement, cytopenias, oral ulcer, hair loss, very few serious infections. And usually we try to minimize these side effects with the use of folic acid or Zofran in some occasions. And we need to monitor for these side effects with regular blood monitoring. Skip this. The second, the other managements that is used in nowadays for juvenile arthritis is also biologics. I'll skip this slide because I think it's very long. So biologics, what are biologics? Are genetically engineered proteins derived from human genes. And they are new class that use monoclonal antibodies or proteins to target cells and cytokines that are driving the inflammatory process in juvenile arthritis. How do they differ from conventional DMARDs? They are very targeted. They target specific cytokines, specific inflammatory cells in the process of juvenile arthritis. So you can imagine they are like laser beams. They are not like methotrexate conventional DMARDs where they hit many inflammatory cells. They are very targeted, hitting specific cytokines. So what are the indications of biologics overall in juvenile arthritis? If there is failure of methotrexate or side effects of methotrexate, or there is partial response to methotrexate, remember in the era of biologic and JAK inhibitors, we aim for full disease control, remission. So even if the methotrexate worked but didn't work properly after 3 months, then you need to consider either switching it or add something for tighter disease control like biologics. Some cases with axial involvement in fasciitis-related arthritis or psoriatic arthritis, based on the studies, you go direct for biologics. Axial involvement, usually methotrexate resistant. So these some occasions that you go direct for biologics. And in uveitis, which is not responding to methotrexate. So we have many biologics, anti-TNF, anti-IL-1, anti-IL-6, abatacept, recently JAK inhibitors. So what are the side effects of biologics? Increased risk of infection, which is not a major concern per studies. And as any drugs, they could lead to allergic reactions. And this is mostly prominent in anakinra and infliximab with IV infusions, but it's not very common. Risk of malignancy, this is, we have to take the consent for family for potential increased risk of malignancy, but many studies suggest that the increased risk of malignancy, which was not found in pediatric, many found lymphoma in adults, we can judge, is it the biologics which lead to increased risk of lymphoma or actually the disease itself? You know, so it's not conclusive, but we have to keep the family on board. You know, parents nowadays, they read many things. So there is potential increased risk of malignancy, but it is not definitive because juvenile arthritis and autoimmune disease, anyway, they are at increased risk of malignancy. Autoimmune phenomenon, they found that after we have to do autoimmune screen before starting biologic, they found that there is increased risk of production of antibodies like ANA, but very rarely it progressed to systemic autoimmune disease. Coming to the biologic workup, before we start the patient on methotrexate or biologic, we need to screen them for infection, viral infection, varicella. We need to screen them for TB with PPD and X-ray. And we need to, even after establishment of biologics, we need to monitor these annually. When it comes to vaccination and GIA, usually if not the patient not on DMARD or not on biologics or JAK inhibitors, they can receive the live vaccine. However, if the patient maintained on DMARDs because these are immunosuppressive or biologics or JAK inhibitors, we need to avoid the live vaccines. We can give the killed vaccines, but we know sometimes there is decreased immunogenicity. They don't produce antibodies the way they will be protective. And we advise for annual flu vaccine, which is the inactivated vaccine. And sometimes we also consider pneumococcal booster doses. Last result, and I say there is a room for JAK inhibitors for refractory cases, especially poly-GIA or uveitis, or though it's not proven, but there are trials which is successful in management of refractory GIA. The last result for management is autologous stem cell transplant, alternative if we exhaust all the available biologics, JAK inhibitors for refractory juvenile arthritis, and the future directions with improved awareness, previous combination therapy, gene profiling, targeting therapy. I'm sure we will be more aware about markers and different subtypes of disease that we will target with the proper agent. Coming at the end to the outcome of prognosis of GIA, always we tell the parents it's impossible to identify whom will remit versus whom will not. Okay, it's a very difficult question for a pediatric rheumatologist. But what we instruct the parents overall guide that the majority of oligo-GIA, simple ones with absence of poor prognostic factors that I mentioned earlier, will achieve remission. But arthritis remission doesn't mean always uveitis remission. The risk of uveitis is still there. Overall, the majority of poly-GIA or extended oligoarticular, they will not remit. The majority, it will be chronic disease. Yes, we can control with many medication, we achieve remission, and we could give a trial of withdrawal of medication, but there is a high risk of recurrence. And in systemic GIA, there is a rule of 3, 1/3, they could have monophasic phase, and they will have remission for life. 2/3, they will not. They will have aggressive disease, polyarticular or systemic course with fever and rash. So in conclusion, as you see, juvenile arthritis heterogeneous disease group with many controversies regarding treatment option and clinical course. And the literature suggests that treating inflammatory disease early and aggressively to switch off the immune process lead to better long-term outcome. And treatment now aims for minimal disease activity and quality of life and remission. And MDT approach is mandatory to optimize disease control. Therapeutics in the GIA progressed rapidly, as you saw, over the last decades, and disease activity measurements are important tools to hit, treat, to target in terms of treatment success and follow-up. And in the era of biology and JAK inhibitors, we became more ambitious and patient outcomes vastly improved. And we will shift to more targeted therapy with availability of biomarkers, pharmacogenetic, for beneficial rule for tight control for juvenile treatment and prevent the long-term complications. Thank you.
Thank you, Dr. Wafa. Both the speakers back to back, you've given a good overview of both complex conditions that we encounter as pediatricians. We will just see what the audience questions are, and after that we can have a discussion. Let me just go over. I do not see
Excellent
any...
presentation by Dr. Both the speakers, Dr. Wafa and Dr. Anand. So thank you very much for the enlightening on the rheumatology updates.
There are some specific queries about certain elements talked about by both the speakers. Let me read them before I take you over to interesting discussion amongst the speakers, as well as leading to further discussion. One of the questions is, IVIG was shown to have one of the complications of aseptic meningitis. How would you distinguish between the actual aseptic meningitis that is part of the clinical presentation of KD, which should you distinguish between the two? Would it matter to distinguish between the KD aseptic meningitis or IVIG-induced aseptic meningitis? Dr. Anand, how can you take that question?
Yeah, so the thing is, normally when you start giving IVIG, fever starts coming down, the irritability starts coming down. But if your irritability goes through the roof, you have a child who's become more irritable, then maybe, because the IVIG induced irritability or aseptic meningitis can set in a few hours after the infusion, during the infusion, or it can set in 8 to 10 days later too. So there's a lot of age range. So it's not a very common complication. Literature says it is less than 0.05%. So it's 1 in 5,000 patients develop it. It's not very common, but it is important to keep in mind. So if a child has become more irritable on IVIG, maybe changing the brand or slowing the IVIG infusion might be something you might consider. But beyond that, it's a self-limiting condition. Most of the times you don't need to treat it, allow things to settle down, reassure the parents, and wait it out.
Yeah, the next question was, how would you manage in case you encounter a drug-induced aseptic meningitis? And as we gathered, it would be from the
Just
symptom
wait and watch.
profile only you diagnose, and then wait and watch approach. Yeah, thank you, doctor. I do not see many questions beyond this. There are some new
Question for
questions.
Dr. Wafa also. How common is psoriatic arthritis in children?
Psoriatic arthritis, as I mentioned, around 10%, but it's very tricky diagnosis, if I said. I mean, it's very extensive topic, but psoriatic arthritis, one of the challenges to even to a pediatric rheumatologist, because it's not as simple as it sounds. Usually you don't have both together. So if you have arthritis, usually they present like oligo at the beginning, okay, where one big joint like knee, ankle, wrist. So you will think it's oligo, but what's the clue for psoriatic arthritis is sometimes the family history. If there is family history of psoriasis, then this is not simple oligojuvenile arthritis. The other clue is when is, for example, one of the small joints of the finger involved. This is not typical for oligo, or there is dactylitis. So this is a marker like, oh, this is not simple oligo. And psoriatic arthritis is more, you need more aggressive treatment than simple oligo-GIA. Simple injection, it won't benefit these children. So it's around 10%, but not easy to diagnose and not very easy to treat as well.
In our series of about 1,000 patients of GIA, psoriatic arthritis, we have found only 1%. Only 1% of our patients
No, I'm
with
seeing quite.
psoriatic is extremely rare in pediatric population. And as Dr. Wafa mentioned, presence of dactylitis, nail changes, skin changes, or family history will give us a clue that this is a psoriatic arthritis.
Thank you.
I don't have our own data here, but I'm seeing some cases, you know, I don't think it's as rare as 1%.
No, but I'm talking about our
Yeah.
live
Yes,
1,000 patients. So when we
yeah.
compare, it's extremely rare in Indian population. I can't speak
Yes.
about population in the Gulf or West.
Okay.
The other question,
And
what
the
is
question,
the steroid or naproxen for treatment?
Sorry?
there's a
Sorry.
What is the
question on systemic onset GIA. Well, the question, there was a reference in the presentation. The question asked whether it's steroid or naproxen. Well, doctor, you can reiterate the answer.
Sorry, I didn't get the question. Sorry for that.
Systemic onset GIA, the question goes like this: what's the treatment? Is it naproxen or steroid? Meaning the presentation explained it, but you can take that.
Yeah, sure. So it used to be always in the old school. I mean, there are spectrum of disease, not one disease, but in overall, NSAIDs used to be monotherapy, mainly for the simple form of GIA, like oligo-GIA, especially if there is no significant effusion, or sometimes in very, very mild systemic GIA. But it's not the case anymore because we have much more extensive drugs. So it's not acceptable to have a long trial for NSAIDs monotherapy, even in the simplest form of GIA, which is oligo-GIA. You could argue 1 to 2 months maximum in very simple knee effusion, which you believe it's juvenile arthritis. So the main rule nowadays for NSAIDs is mainly adjuvant to help you to control the inflammation and pain, anti-inflammation. It's not monotherapy. I don't know whether Dr. Rao agree with me. This is now
The question was SOGIA in systemic onset GIA. The question.
Systemic.
Yeah.
I read the literature. Some of the patients, they manage them with NSAIDs if it's systemic GIA, but to be honest, in my practice in Bahrain or even in my fellowship center, we never take this as the only monotherapy for NSAIDs, but it's reported in the literature in systemic GIA, which is not very toxic. Sometimes a monotherapy of NSAIDs will work, but I never saw it.
I beg to differ with Dr. Wafa. A small percentage of patients tend to have a monocyclic course. Out of 100 patients whom we followed up for 5 years, now we have sent it for publication, it should get published. It's unpublished literature still. Roughly about 30 to 40%, 46% in our patients had a monocyclic course. And it's the most dominant because 27% have polycyclic and 27% had persistent disease course.
Yes.
Those with monocyclic course without significant inflammation, as Dr. Wafa was mentioning, with counts not being very high, arthritis not being very bad, fever not being very high, no evidence of macrophage activation syndrome, maybe a trial of NSAIDs. I usually do that for 1 to 2 weeks if the child is not toxic, not sick.
Yeah.
If they respond, some of them do. Excellent. We can use it for 4 to 6 weeks and maybe taper and stop the NSAID. But many of them persist to have disease. If they have the disease, we can use steroids and methotrexate. But now the current concept is veering towards use of biologics in many of these patients using IL-6 blockade or IL-1 blockade. But in a resource poor setting, I would still use methotrexate and steroids if they don't respond to NSAIDs. And mind you, these are sick, non-sick patients. Sick patients, they directly we use steroids with methotrexate, especially those with arthritis.
Thank you, doctors. While we are leading towards discussion on treatment of JIA, you could just roughly give an overview here. Methotrexate seems to be a DMARD still. What's the practice in your respective areas? Would it be giving a trial of methotrexate? If unresponsive, go to biologics, as conventionally it has been. And present trend is to go for the biologics. And how do you decide it? And a bigger question, when do you want the pediatricians to refer to you? How far can they handle the situation? Can they be handling till the level of monitoring methotrexate? And if they are remissions with methotrexate, can they still be the patients of pediatricians? Would you suggest referring to you beforehand? Both of you can take the question.
First, Dr. Wafa can answer, then I will take it.
Yeah, you can inform our local pediatricians, then Dr. Anand, please.
Okay, so the first question is, when do we use methotrexate? Is it, or you mean when to refer? I mean, the methotrexate,
Yeah, please go ahead, doctor.
Yeah, so the methotrexate, anyway, as I mentioned, it's bread and butter, we call it. Still, it's very good, though it's very old, but it's really working very well, unless there is side effects, and there is a good response rate. You know, I feel like, at least in Bahrain setting, nobody is familiar how to do the workup with methotrexate before administration or the regular blood monitoring. So I think it's not fair for the pediatrician to manage all of this. So I think better to be referred. And we hope we have more webinars to increase the awareness of that. But I don't feel, at least to my knowledge, local pediatrician will not specialized in pediatric rheumatology will do the screen, then the methotrexate, and the monitoring. So I do understand they should be referred. And I think there is one of the questions is when to use biologics. As I mentioned, the methotrexate is the gold standard therapy, maintenance therapy when it comes to overall poly-GIA or oligo-GIA with poor prognostic factor like TMJ, hip joint involvement, raised markers, or very prolonged history of disease duration, then you go directly for methotrexate. But now, as the literature suggests over the last few years, there are some subtypes of juvenile arthritis that directly you should go for biologic, especially axial involvement in the setting of enthesitis-related arthritis or even psoriatic arthritis. In other words, you will waste your time if you start methotrexate waiting for response, because probably there will be no response. So it's better to go direct for axial involvement for biologics. This is one indication. The other indication of biologics, obviously, if methotrexate was not tolerated with nausea side effect, or didn't work, or it worked but partial response, not work enough, then we need to add biologics if there is partial response. If it didn't work, obviously you need to switch to biologics.
Thank you. Dr. Anand, your take?
Yes. Regarding pediatricians handling juvenile idiopathic arthritis patient, yes, they have definitely got a role. They have a role in monitoring the growth, the development of these patients, monitoring for side effects, but monitoring the disease and monitoring, titrating the dosing, I think it is a little bit far-fetched, because this would require assessment of the joints, assessment of the extra articular disease in these patients, be it serositis, be it presence of enthesitis, in enthesitis-related arthritis, uveitis. That's where a rheumatologist, a pediatric rheumatologist, has an extra expertise to look for these and do the right things. But definitely the rest of the routine care is can be handled by the pediatricians. When it comes to management of these patients, a pediatric rheumatology always would be better. And regarding, as Dr. Wafa mentioned, methotrexate is the drug of choice in management of many of these patients, and depending on the subtype, some of the conditions wherein it's non-responsive, or in, as she mentioned, use of axial skeleton involvement in enthesitis-related arthritis, we tend to use either small molecules or anti-TNF agents straight away. If they fail, non-steroidal anti-inflammatory drugs.
Thank you, doctors.
Maybe the methotrexate indication as well for, I forgot to mention, is uveitis not responding to topical steroid eye drops. So when we have uveitis, the first line would be methotrexate, and only if it fails or not enough, then we go for biologics, anti-TNF and tocilizumab, yes.
Yeah, it's recognized to be very important to screen for uveitis, which is one of the sight-threatening complications that we have to be aware. And our responsibility is diagnosing, and when we have initiating treatment would still be the responsibility of pediatricians, and refer timely for adequate monitoring with respective tools, which should be the role of a pediatric rheumatologist, and deciding whether there has been remission or would there be an additional need for biologics would be, again, the decision-making of pediatric rheumatologists. This is what I could summarize. Steering back to the first condition that we started with, Kawasaki disease. Well, that remains challenging. It again is very much in the zone of a pediatrician for a long time before a pediatric rheumatologist gets involved. So how challenging has it been? All the mimics. In India, we have the tropical infections and many pyogenic infections. We saw one of the cases discussed by Dr. Anand, which was being treated as pneumonia. So a lot of such atypical presentations. What are your clues? Do we stand in the same platform as when you diagnose that particular case? We do encounter such challenges even today. What would be your turning point in thinking that we are in fact handling KD in a pyogenic mimic, like several cases that you discussed, Doctor? We will have Dr. Wafa's opinion after this, Dr. Anand.
Yeah. So the most important thing about Kawasaki disease is it teaches you a history taking. It's important to draw a line of timeline of events, because many of these things, because we have had patients who have had red eyes, but the pediatric postgraduate would have missed taking the history. It's important to draw a timeline. These children tend to have hectic remittent fevers, wherein fever is not touching the baseline, very irritable children who tend to have multi-system disease, predominantly involving the mucosal surfaces, involving the skin. If you are having the clinching points would be a non-purulent conjunctivitis, because it's seen in 4 out of 5 patients. If you are having cheilitis with strawberry tongue, seen in 4 out of 5 patients, that is once again a clinching point. If you're having periorbit swelling of the dorsum of the hands and feet, it's a clinching point. If you have a rash in the perineal region with scaling early on, think about Kawasaki disease. If you just disrobe the child and if you see the BCG site activation, because hardly any conditions come with a BCG site activation, think of a Kawasaki disease. A sick, irritable child who doesn't like to be touched, who's irritable even on mother's lap, think of a Kawasaki disease. So it's important to keep these patterns in mind. These are the different pointers which tell you that you are dealing with something more than a usual infection. So that's what you should keep in mind. It is not a single symptom. It's a collection of symptoms that becomes very important in a setting like this.
The challenges come when we are handling pyogenic infection, that's like a pneumonia that you presented, and unresponsive, we would think of a resistant pneumonia. This would be the usual thought process. When would we take so it's a message from today's presentation. Before thinking of in the pyogenic common encounters also, before thinking of resistance, pause and think of possibility of Kawasaki with what would be the additional clues which you would suggest. You would want us to go for a 2D echo evaluation at that juncture, or how would you want us to handle such dilemmas?
No, in the setting that if you are seeing an incomplete, if it's a complete Kawasaki disease,
In
I think I'm sure
incomplete
that you would.
situations.
So if you're
Exactly. You're talking about it's a
incomplete
typical.
Kawasaki, simple tests like urine routine microscopy, which is showing a pyuria, which is culture negative most of the time. Yeah. If you're having LFT, which is showing transamininemia, whereas the AST ALT is quite high, but with hypoalbuminemia, think about a Kawasaki disease. If you have leukocytosis, leukocytosis starts earlier than thrombocytosis. Thrombocytosis, think of a Kawasaki disease. If you have any of them, and anemia, which is significant, and if you have any 3 out of these positive with a child who has, say, febrile illness, which has been going on for more than 5 days in a child and more than 7 days in an infant, think about a Kawasaki disease. If your ESR CRPs are high, ESR more than 40, CRP more than 3 mg/%, think of a Kawasaki disease. So it's important to put everything into a proper perspective, look at it, and most of the times you'll be right. And always a 2D echo is always warranted, because if you're having, as I said, coronary artery dilatation, coronary aneurysm, a proper fusiform or saccular aneurysm, or presence of, say, decreased ejection fraction, pericardial effusion, or dilatation, then I think you should, or mitral regurgitation. Out of the 4, if 3 are present, think of a Kawasaki, and it would be worthwhile treating them with IVIG early on rather than wait.
Okay, well, what's your take on the role of biomarkers? Where is the KD research heading in this field?
And biomarkers, checking the
For
IL-6.
clinical use, yeah.
Clinical use, NT-proBNP might indicate presence of myocarditis. Normally, these values in infant and children tend to be less than 400 or 500, and they climb up to more than 1000, 2000. So it only indicates there is a myocardial stress. And if their NT-proBNP levels are high in a setting like this also is it gives you a push to go towards Kawasaki disease and incomplete Kawasaki disease, and maybe initiate treatment early on. And it has always been noticed that earlier you initiate treatment, the better is the chances of avoiding a coronary artery aneurysm. The later you initiate treatment, you might have aneurysms which are not only coronary. We have had patients with systemic aneurysms involving axillary arteries coming with masses in the axilla, brachial artery aneurysms, or even iliac artery aneurysms. So that is something which we need to avoid.
This biomarker is identified with IVIG refractoriness also.
Biomarker only indicates the presence of your myocardial dysfunction. It will not indicate it, because myocarditis might not go hand in hand with coronary artery aneurysm. These are two events which happen separated by a few days to weeks. So myocarditis doesn't portend to CAA, that's coronary artery aneurysm, but there are no single biomarker which can help apart from presence of CRP elevation according to the SONS criteria, which was published in 2024.
CRP3 happens to be a common finding, isn't it? CRP3 cutoff?
CRP3, yes. Now, in the SONS criteria, it's more than 13.
13. Okay.
SONS criteria, it's more than 13, Asian descent, and presence of coronary artery aneurysms.
There have been revisions on risk stratifications recently. Any new?
No, the thing is,
Thanks.
we need to have country specific, because I don't think you can use the North American risk stratification or Japanese risk stratification in the Indian context. Our genes are different. We need to have our own data set which tells us which are these patients which tend to develop a coronary artery aneurysm. So I think it's high time that we work on our population and come out with risk stratification strategies so that we can prevent coronary artery aneurysms. Initially, it was treatment of all Kawasaki's with IVIG and aspirin. As 2000 set in, it became identifying those who develop coronary artery aneurysms. Now, things are evolving. It's a fluid state. As time goes on, I think we'll become better.
Noted. Then we noted you saying aspirins reaching negligible dosing, and then as of now, we have become very conservative in utilizing aspirin in the first line management.
Absolutely. Whatever, it is a legacy medicine. And taking out a legacy medicine and introducing a new medicine is not very easy, because it means changing the mindset of people. The Kawasaki experts themselves were so hesitant about using steroids that when Dr. Jane Burns had come to India, she said no steroids. Dr. Sujit also advocated no steroids until recently. Things have, because to unlearn and relearn, it takes time. So to change a mindset, it's not going to be easy. And steroids, if I may say so, is a better drug even when compared to infliximab. Because steroids have shown CAS tend to reduce with the steroids more than infliximab. So I prefer to use steroids upfront in many of these patients.
Thank you, doctor. To take the discussion in the direction of future, genomics seem to be heading into our practice arena. Precision medicine has reached us. Where do you think Kawasaki genomics going? When do you think we would possibly be utilizing genomics for our decision making in Kawasaki disease? Are we there? Are we seeing ourselves to be there soon?
There have been multiple genes which have been propounded to be associated with refractory Kawasaki disease, including ITPKC, caspase-3, and the gene which is associated with the receptor for IVIG. So we'll have many more genes coming up. But the problem is, even if you know the genes, we need to get the results within 24 hours, and that is not very easy. So if you have a patient with Kawasaki disease, I can't wait for 3 weeks for the genetics to come in to say, this child was a refractory KD. That time has already passed, and this child already would have ended up with an aneurysm. So in a KD, we need the results within 24 to 36 hours. So if the genetics come to that, I think it makes sense. Otherwise, it is just an academic exercise. The horse has already bolted, and you are only going to catch its tail.
We probably are getting there, going by how TB diagnostics was reaching the standards. Yeah.
Let's hope that we reach there, and because I think ultimately it is, if it is going to prevent aneurysms, nothing like it.
There are some questions coming by, but I cannot really see. Dr. Mohammed, if you can help gathering some questions from the discussion there, from the chat box. Dr.
Sure.
Wafa, the same question. Where is the genomics in JIA? Doctor, you're muted.
I think there is a lot of studies on genomics, but with the clear correlation with the response of specific subtype with genomics is not yet conclusive. But what is very advanced in juvenile arthritis is the biomarkers. A lot of biomarkers now are there to guide the treatment. probably which agent, which biologic will be most effective in this disease. Still, they are working, I think, on genomics. There is no conclusive results from my literature review. I don't know if Dr. Rao will agree with me or not. This is what I know about.
So regarding genomics in GI, the thing is, it's not a monogenic disease. It's a polygenic disease. You don't have a single gene, which
Only systemic, yeah.
So it is a polygenic disease, and a polygenic disease, you can't have a single gene which determines the disease.
Sorry for that interruption. This is what we are encountering every time we are reaching the conclusion session.
George and please.
I request all participants to mute themselves. I wouldn't know how they got unmuted.
Thank you. So it's because it's a polygenic disease, there are multiple genes. So genomics in these autoimmune diseases, especially the JIA subtype, it is not possible, but you can use HLA markers, human leukocyte antigen or MHC markers, which predict a certain subtype to have more uveitis, a certain subtype to have like HLA-B27 indicates that this is a enthesitis related arthritis. So it helps to determine which subtype would require what type of treatment. Now HLA-B, now to keep in mind, GIA is not a single disease. It's a heterogeneous group of disease. Even in that, a systemic onset GIA it's a heterogeneous disease. Oligo GIA is now separated in between ANA positive and ANA negative, similar to poly, wherein RF positive and ANA positive are two separate subgroups. Some patients tend to have everything negative. So it is not a heterogeneous, it's not a homogeneous disease. There are no unique genomic markers apart from, say, HLA-B27 and certain HLA DR4 series, which tell you that uveitis risk might be high, or this patient will tend to have enthesitis related arthritis. Still a long way to go before genomics. A single gene might not come in, a complicated array of genes might come in, which subsequently might guide us that this is the way you should treat these patients based on the genetics and the proteins which are elaborated by those genes, but not yet easily available.
Yeah. Just to add, there is also a very hot topic now about systemic. As you mentioned, there is no genomics, but there is HLA-DRB1 and the possibility of high risk of interstitial lung disease in the setting of systemic GIA, but there is no definitive, but it increased the risk. As Dr. Rao said, it's HLA and the possibility of developing complication or a subtype of arthritis. It's very complex, as he mentioned, and it's very difficult to say it's one disease, heterogeneous. And actually, there are many classification after the ELAR done, like Printo and but they found still the ELAR so far is the best, but still within the same subtype, there are many subtypes, if you know what I mean. And even the oligo with poor prognostic factor, it behaved like different. So it's quite complex and heterogeneous.
It's very artificially clubbed under one terminology, JIA, whereas it's many diseases.
Yeah.
The only common thing is the presence of arthritis.
Arthritis.
All of them are different.
Sometimes they may be absent in a SOGIA also.
Yes, systemic GI, exactly. The arthritis, there is a lag till you find it, or sometimes just arthralgia. So even the arthritis in systemic onset, you will be very lucky to find it at the beginning. So, to make it even more challenging.
And many a times, Kawasaki, many of these systemics would have been diagnosed as Kawasaki in the beginning. When the disease doesn't settle down with IVIG, that's when you think whether we are dealing with something else, because it comes with febrile illness. It can be hectic initially with presence of rash. They would have received IVIG, but when that doesn't occur and the child develops arthritis subsequently. Lo and behold, we are not dealing with a KD at all.
Yeah, very good. And the COVID era also teach us a lot about,
Yeah,
AMH.
I was
MISC,
coming to
with
that
MISC.
question.
Yeah, with
How it
MISC.
changed. One of the
Yeah,
mentions of Dr. Anand was that incidence is reduced, but then another
yeah.
parallel condition, which
MISC, like
which
MISC, it has
MISC
similarities with, yeah. And
changed the
many,
landscape of KD in so many ways,
Yeah.
actually.
yeah, MISC, like it teach us a lot. And I don't know whether Dr. Rao will agree with me. Even the Kawasaki and the MISC, you can argue, is it simply vasculitis or it's a post-viral syndrome? Like even the pathophysiology, it's not very accurate because straightforward vasculitis will respond to steroid, as simple as that. But it's more than that. The Kawasaki, it's a mixture of vasculitis and response to post-viral illness or post-viral trigger. And the same with MISC. MISC is not also very simply only vasculitis. It's a reaction to COVID or previous trigger. So it's quite complex.
Absolutely.
Yeah.
Fully agree.
Yeah. And
That
many
brings us
MISC
to the
patients in the era, later on, they're found to be systemic GIA as well, as the same way as Kawasaki, like Dr. Rao mentioned, labeled as MISC, and then with recurrence, then it's found to be systemic GIA.
The reason was that it
Mm.
was such an open condition and everybody's
Yeah.
COVID antibodies were checked. And most of us had COVID antibodies. And it's
Yeah.
easy to label, and you give IVIG and steroids, they will get better.
Yes.
After the effect
Exactly.
wears off, the true color will come out.
Yes. Unfold. Yeah, exactly. Unfold.
Thank you very much. It has been an interesting follow-up discussion we had. It's been the most prolonged CME post-discussion we have had so far, I think. We will sign off. I would like to request Dr. Anand to give some take-home messages while Dr. Wafa can follow up. Some take-home messages for the practicing pediatricians. That's what the whole intention is for the CME. Dr. Anand,
Yeah,
please.
generally when it comes to pediatric rheumatology, it's a branch of medicine wherein clinical medicine, which all of us love, still holds good. So it's important to look at the patient as a whole, take a detailed history, do a thorough examination. Many of these diseases can be diagnosed without many tests. So it's important to give time to these patients, assess them completely, write down the main features, which organ systems are being involved, and then look at investigations. And investigations will have to be focused with regards to the condition which you are looking at. Thankfully, we have the new AI tools, including ChatGPT, which come in very handy. I think all of you will have a internet connection and a computer next to you or a smartphone. So it's very easy. If you can just understand which are the organ systems which are involved, what is the phenotype of the disease. You just have to key it in, and I think many times ChatGPT helps you diagnose these conditions. You can always have a phone a friend. Dr. Wafa is there in Bahrain. You can just call her up and ask her. She'll be kind enough to answer you. Even I'm there. So a WhatsApp message or a call, and we might just be as helpful as ChatGPT. I don't have any shares of ChatGPT
Definitely
or
more, I
AI.
guess.
Huh?
Definitely
More
more
help.
than ChatGPT, I guess. We would
No,
count you
no. I
to
think
be a
time
far
will come.
superior than that.
Time will come wherein even I
We
even I
become obsolete.
ChatGPT. Yeah,
You're
yeah.
foreseeing that.
No, the thing is, I might not become obsolete with regards to the differential diagnosis. I might not become obsolete to the clinical skills. That is the only thing which will hold us through, because ChatGPT can't pick up things which I can pick up on, say, physical
We'll
examination.
have to feed ChatGPT to give us info, but then that
Yes,
depends on
but you
what
have to
we
put in
gather.
the prompts will have to be proper. The prompts will have to
Exactly.
be proper.
So
It's important to give the
our relevance still remains.
until we can pick up things clinically, which a ChatGPT or any AI can't pick up. So it's important that to stay relevant, we have to still keep on honing our clinical skills.
Yeah. That's
Genomics
a
are there.
strong message.
Genomics are going to be helpful, but it will depend on your phenotype, which you provide to your geneticist. So wherein, once again, a good clinical history and a thorough examination helps you narrow down the phenotype. So that's how we discovered quite a few set of diseases which are very unique. So it's about documentation of these and following them up.
But the exciting advances in genomics is about screening, like
Correct.
right from newborns to the presence of phenotypic details are no longer the focus. Genomics are going leaps and bounds.
Absolutely. It has helped us discover quite a few conditions which we never thought we could ever diagnose. And turnaround time is short, the costing is less, but with increasing load, errors in reporting also comes in. So it's very important to look at it closely.
Thank you, Dr. Wafa. Your message to all of us.
Yeah, Dr. Rose says, mashallah, more than enough. I will just emphasize what he said. I'm always telling my students, my residents, history. I mean, this is the tool to diagnosis. What we do as a workup is just complementary. And if you focus on the presentation, the GIA labs are negative. It doesn't help us. It's the history, the progressing of the symptoms, the duration, the clinical assessment. That's what helps you. And I would say rheumatology is always many diagnoses. It's a diagnosis of exclusion. The based on diagnosis rheumatology based on excluding other common causes like infection, like malignancy. So to be a good pediatrician, a good pediatric rheumatologist, you need to be a very good general pediatrician. And good general pediatrician or subspecialized won't come without most important tool is the history and the clinical sense of the patient, which can't be replaced by ChatGPT. Yeah, I totally agree with Dr. Rao. I mean, clinical sense should be there. Yeah. And the look of the patients with the history. Yeah.
Thank you, doctors.
Thank you very much.
Been very exciting CME, I would say. Thank you very much. And as Dr. Anand said, the perk here is networking with you both, and we would use you for any references, in first-hand references. Thank you very much for
Pleasure.
being us.
Thank you. Thanks
Thank
a
you
lot.
so much.
Thank you very much.
Bye-bye.
I would like Dr. Mohammed Salman, can you deliver the vote of thanks
I'd
before
like
we sign
to-
off? Thank you for the interesting audience also. Thank you very much for keeping our CMEs the top notch these days. We are 500 plus amongst the registrations. Thank you. Dr. Mohammed Salman,
I would like to
please.
thank, I would like to thank both speakers and also our colleagues in the IAB in India, and sure my colleague Dr. Vanitha for all the work to keep this series of the webinar. And I just remember the last November when we are met and discussed that we will having a plan to create a monthly webinar. And today we are reaching the sixth webinar. I think this is a good and excellent achievement. And from the delegate point of view, it's also we're starting with a less than 50 delegates attending, I think the first, and now we are reaching to more than 500 delegates attending the webinar, and I can see now we have more than 200 delegates remain with us till the end, and I think this is an excellent achievement in managing this collaboration between the IB and the AMH. Thanks, Dr. Wafa. I know very short notice when I invite you to join us in this webinar, but you make a great presentation. And sure, thank you for Dr. Anand also and all the IAB team.
Thanks a lot. Thanks for the organizing committee.
Thank you, thank you, thank you all.
Thank you.
Thank you, Salman. Mohammed.
Thank you, thank you, thank you.
Thank you,
Bye-bye.
Anita. Thank you, Wapa,
Thank you.
Anand,
Thank you.
Yogesh ji.
Yeah. Thank you for attending, Dr. Baswaraj. In spite of the Sunday family time, all people are here to enjoy this excellent webinar. And Dr. Anand and Dr. Wapa done the excellent way and the presentation. We enjoy a lot, madam. Thank you.
Thank you, Yogesh ji. Thank you, Vastav sir ji. Thank you.
Yeah, Sunil ji. Bye bye. Yes, close, please.
Next
Saji.
month.
Thank you.
Yes, sir.
Bye.